Welcome back, everyone. For our next section, we're going to be discussing the psychological impact of allograft loss with a fantastic panel. And I'm joined here by Uwe Korst, Beate Ditzen, and Vivek Jha, and I'd like everyone to perhaps start by introducing themselves, and I'll maybe give you a challenge of a question to open up with, and then we could open up the panel for questions from the audience. So I guess what I'd like everyone to sort of start is, after they introduce themselves, maybe start by saying what you see as the biggest issue when it comes to the psychological impact of graft decline and graft loss. We can also get to what we can do about it, and also, if we can, address what further research or studies are needed. So Uwe, why don't I start with you to introduce yourself and see if you could tell us a little bit about those questions.
Who's going to start?
Oh, you are.
Okay, no problem. First of all, I would like to introduce myself. Just give me a minute to speak about my patient journey. For my education, I'm IT engineer, or I was IT engineer for lots of years. I traveled a lot. And my patient journey, I was diagnosed with ADPKD when I was 25. I went on dialysis, so my kidneys failed when I was 48 years old. My life changed, well, not dramatically, but it was a big change at all. I went on PT, peritoneal dialysis, which gave me some opportunities to continue working. When I was 50, I received the gift of my life. I received a transplant from my wife. That was really wonderful. And today I'm 60 years old and my condition is very good. My kidney is still working very, very, very good, excellent. And I'm thankful for each day. And I know that my kidney could fail also the next days or so, but I hope the kidney will not fail. So concerning your question, I would like to start. What are the biggest issues concerning psychological impact when the graft declines or the graft will be lost? Of course, my graft still works, but for patients, when they get on dialysis or even when they lose their graft, it's a big disaster because life will change in most cases dramatically. So why is that the case? And what Kevin already mentioned, patients fear to return on dialysis or to go on dialysis more than death. That's really true. I think not for all, for every patient, but in general, it's let's say for some people a suicidal risk because they don't do it. I think I don't know very few patients only, but it's suicidal because they think about what's the life going on and they have unrealistic thoughts. And that's the most problem case because they see parents had been on dialysis, let's say 20 years ago, and it was terrible at that time. Today, it's with much better dialysis. So dialysis, you all know, means 15 hours per week on dialysis, changes life completely, social life changes. And most patients know it already from the, I think when the graft may fail, so the transplanted graft may fail, they know it already because they received a life-saving transplant several years ago. And most people have a long-lasting graft, and that's wonderful. So why is it relevant? Why is it relevant, and why is it a psychological issue? Because first of all, the quality of life, which is important for everybody of us, is lower, and there are a lot of several studies, SF36 studies and questionnaires, which shows that life, quality of life goes down. Life expectancy will be shorter if you go on dialysis again, and even more shorter when you go on dialysis for a second time. The risk of death is there, more hospital visits, etc., etc. And the most important thing for most people when they do have a normal life, more or less after going on dialysis, there are a lot of symptoms on dialysis. All doctors, you know what it means. It's fatigue, it's pain, vessels, endurance, lots of endurance and all that things. And the important thing is the work. You may lose your workplace, and then means you lose your budget you have for your family. And also it means some problems with insurance. For example, we heard it from Kevin, I think. And the psychological challenges are very high. It depends on the psychological stability of the patients, and there's a quite big range of how stable patients are, depending on a lot of factors. We heard it during some earlier presentations. What is your social environment? What is your, where do you come from? What is the country? Are you from a rich country? Are you from a poor country? And there are a lot of things to take into account. And I think from a patient's view, it's really normal to have from time to time some, let's say, dark thoughts. And that means you think, okay, how will my life go on? And it depends really what is the environment? Do you have a family supporting you? Do you have patient support groups? Do you have psychological supports, etc.? And even if the kidney disease, if you have a rare kidney disease, well, there are a lot of rare kidney disease, it's even difficult to find a good expert, and even the dialysis doctor may not know the disease in detail. So later on, I could also speak about what could be done, but I guess the others have also some, what are the burdens?
Thank you. So I'm going to ask Vivek next, and I'm going to leave our psychologist for last to give us some perspective. So Vivek.
Thanks, Michelle. So I'm Vivek Jha. I'm a transplant nephrologist from India. I'm a past president of the International Society of Nephrology. My practice in India has pretty much been in the public healthcare system, which has informed my worldview of how patients access care, what does it mean for them, and so on, just in the broader context of chronic disease, but specifically in the context of transplant. So what does transplant mean to our patients when after a variable period of dialysis they get it? It of course means freedom, independence, improved quality of life, but in our context, it also means reduced cost of care and possibly providing for their family, which they have been unable to do while on dialysis in many situations. It's also worth mentioning that transplant is a substantial investment, literally in low resource settings where people have to pay for their care themselves. And there is a lot riding on its success. For people in many countries, a successful graft is equivalent to survival. So if because they have pretty much invested everything in getting a transplant, and so if that graft fails, they perhaps don't have means to continue future treatment. Now, with that background, the transplant surgery itself brings with it numerous psychological, existential, relational, and social changes for patients as well as their family. That's also important. So we have to recognize the effect of all of this in their family. And these type of changes are both positive and negative. It's important how well these patients have been prepared for transplant. Our patients are under special pressure if the kidney comes from a living donor, which is mostly the case in my country, for example. These patients pretty much start experiencing psychological issues right from the time that they recover from their transplant surgery, which of course includes fear of rejection. And they have a seesaw of emotions, a number of negative emotions, etc. And as has been said again and again, that newly transplanted patients, once they see the sea change in their lives, they start thinking that they would rather die than ever go back on dialysis. So with that context, of course, graft failure would be considered a setback in quality of life and would provoke provoke intense negative reactions. One of the important negative reactions that we see is guilt, because transplant patients, unlike patients with other chronic diseases like diabetes or hypertension, we often allow patients with these conditions some sort of cheating or a holiday. They are allowed to miss a few doses of anti-diabetic drugs or antihypertensive drugs. But transplant patients fear not missing even a single dose of their anti-rejection therapy, and because of what it might do. In the context of a transplant that has started to fail, of course, they ask the question, what can you do about it? Because they want something to be done about it. And as we discussed in the initial part of our session today, we don't really have very many therapies that can slow the progression of a failing graft, not even ACE inhibitors. We don't know about SGLT2 inhibitors. And this lack of therapies is extremely frustrating for the patients. They go ask for second opinions, and sometimes they get conflicting opinions, and that doesn't help with their psychological issues. So the consequences and the cost that a failing graft has for the patient, but also the medical team and the healthcare system is quite substantial. Many of the transplant patients with their failing graft, just because they're so frustrated, they refuse to get themselves listed on transplant, as has been mentioned already. And the major setback that they get in terms of pursuing their future goals is immense, and clearly takes a lot of toll. And a number of factors that might determine it, whether the graft failure is expected, unexpected, what is their attitude about and knowledge of the transplantation process of what might happen. Many patients just live in denial for a long period of time, and that actually might be responsible for what was discussed during the initial part of the conversation about why failed transplant patients do worse after getting back on dialysis, because they resist going back on dialysis also, which is related to their psychological challenges and how they cope with this illness and their treatment. Many of them withdraw and are not willing to work collaboratively with the teams that manage patients with failing graft. So this denial is important, but sometimes there is an opposite reaction also, which is the reaction of grief, which also causes problems, irritability, depression, anger, etc., which has immense negative implications for their patients and their families as well. So this is the range of issues that we have faced in managing, a variety of patients, large number of patients during their journey of transplantation, whether or not the graft is failing. And of course, when the graft starts failing, then these issues become even more acute. So I'll stop here, and maybe we can come back to some of these points.
Thank you. Beate, could you introduce yourself and maybe share with you what you see as the biggest issues in this arena, and thoughts on what we can do, and potentially if you want to mention research, that's fine. If not, we'll get to it as well.
Yes, sure. Thank you. My name is Beate Ditzen, and I'm working as a medical psychologist, leading the Department of Medical Psychology at Heidelberg University in Heidelberg, Germany. And so I certainly come from a psychological perspective with my points in this discussion. And there are basically three major points I'd like to make. The first is that I would like to advocate implementation of psychosocial research findings and psychological concepts into the evaluation of medical outcomes and clinical care in kidney transplant patients. And that has been mentioned throughout the whole conference today, and I'm sure will be discussed during the coming days. And so I absolutely agree with Uwe and Vivek in what they said already about the psychological consequences. And here I'd like to make the point that not only the psychological consequences, but also what, from a psychological perspective, people bring in to the situation when they expect to receive a transplant, or when they are thinking about donating. And it has been shown from research that a bit more than a third, up to half of the donors are family members. And so the relationship between the donor recipient and the donor, this needs to be taken into account. And this leads me to the second point, to integrate the psychological concepts, but also such as expectations, or later perhaps grief and subjective well-being and quality of life. And the quality of life research, that's something that Heidelberg is really strong in, also the department that Martin is leading. And so here I'd like to make the point that here it's important to focus on the dynamics that develop during or following transplantation and the adaptation to transplantation. So quality of life and also the donor and recipient relationship, these are not static concepts, but dynamic concepts, and they might be predicted by psychological traits in the beginning of that journey, but they also might tremendously change during that journey. And so a repetitive or a repeated questioning about what the situation is now, what the relationship between the donor and the recipient is, what the consequences for the family and for quality of life in the recipient are, that would improve our situation, so that we can ask about their situation and then try to adapt to that. And with your last question, what I would think about what we can do. Here, I basically much rely on psycho-oncology interventions and psycho-oncological research, because this also has to deal with a situation that is from a medical standpoint given, but confronts the patients and also their treating doctors, nurses, and medical personnel with end-of-life questions, with grief, with anger, with intense emotions, and to deal with these intense emotions and how to work with these intense emotions is one aspect that we can draw upon from psycho-oncological research and interventions.
With that thought, I just want to, and I want to ask a question as well, and I ask a follow-up as to whether, as non-psychology providers, and thinking about your comments about the oncology world, do providers, physicians and others, would we benefit from psychology training, communication training, or having embedded psychologists in the units? How do you think that we could benefit our patients in that regard?
Yeah, that's a topic that I'm dealing a lot with as a medical psychologist. So working as a psychologist in medicine, so in the medical faculty. And I think there are basically a lot of basic aspects that can be trained to and learned by all people working in medicine, and here in this specific topic in kidney transplantation. And these are basic communication competences that will help to interact with the patient, but also with his or her relatives. And then when it comes to psychopathology, to psychological disorders, to mental disease, then of course psychiatrists, doctors from psychosomatic medicine, or clinical psychologists need to be involved. But with regard to counseling and the daily work in a clinical setting with patients and their relatives, I think that basic concepts of doctor-patient communication, nurse-patient communication will improve the situation and also will improve the quality of life of the patients. There's not a whole master studies in psychology needed for that.
Thank you. I know you had a comment or a question you wanted to make.
I want to add some aspects. For example, first of all, I was very surprised that psychonephrologic studies or education is nearly not available, at least in Germany, and I guess the same is in other countries. Psychologists are not trained on nephrology issues. So I was a little bit surprised about this. Second point, communication between doctor and patient is very, very important. And I know that they are very skilled doctors, especially at university. It works very fine. But on the other hand, there are some other doctors where it does not work. And they say, for example, I have got ADP kidney and the size of the kidney is bigger. And so some doctors say, please lose weight. But that's not the solution. You cannot solve the problem concerning ADPT, for example. A solution is also, I think the mental health is really a big challenge for patients, and therefore patients quite often, also myself, need somebody to speak to. This could be a family, so it could be my partners, it could be a patient support groups, social workers. There are a lot of institutions available. At the end, also psychologists. The problem with psychologists, from my point of view, it's very difficult to get access to them. In Germany, I quite often hear from other patients, oh, it takes half a year for my consulting time, and that may be too long because sometimes it's very urgent to do something. And as a patient representative, I had a lot of telephone calls with very urgent questions. Of course, I am not a psychologist, cannot support person, but I can speak to them and say, okay, please do this and that, and go to some other stations. The second thing, so mental health, it's very, very important, and it needs to be supported during the complete life cycle of transplanted persons. Some patients need it more, some less, but anyhow, it's very difficult to speak to somebody. The second thing.
Oh, no, go ahead. I'm sorry.
The second thing for me is concerning, we heard that adherence is a point. And I think, I don't know who said it. I think I saw a study where 20.6% of immune suppressiva are not taken or not regularly taken. And so, of course, that patients may lose their kidney. And therefore, from my point of view, it's very important to have better adherence, improve the adherence, whereby it could be with training. I think we will not reach all of the 26% or how many percent at all, but we need to improve the adherence. And when I remember I was in clinic, I get some advice, but I thought I had so many thoughts in my mind, and therefore also after you lose the hospital, you need some training. I think regular training can be done by newsletters or whatever. There's so many digital solutions. Second thing is, or third thing is a model of care. We had some discussion about the model of care. I guess we will speak about model of care later on. And I was really surprised when I did a review in the net. That means I had a systematic review was done in a paper, and there is nearly no evidence what the best model of care is. I have some ideas what I think would be a good model of care. So let us discuss in our group tomorrow or the day after. Yeah, I think that. I think, and also digital solutions, they're available in most countries, and it's quite easy to set up digital solutions, and we have artificial intelligence. So much things could be done to support patients. And just by the way, I was in a, how it called, anyway, I worked on for heart disease patients. I worked on a 24-hour challenge. At the end, we defined an app for supporting patients, and it's going on this market next year also in Germany. And I think a lot of things can be done concerning digital health solutions. That's all for the moment. Sorry.
Thank you. Vivek, I think you wanted to make a comment or had a question.
Yeah, thanks. I just wanted to expand on some of the discussion that we are already having. Is that in addition to us becoming psychonephrologists, which might be somewhat difficult, I think we should also think of becoming social nephrologists and try and understand the social context of patients, because that is perhaps relatively easy, because these patients have been with us for years and years. And so we do get to understand their context. And if we try to do that, perhaps we might be able to better communicate with them and thereby identify if there are issues that require more detailed evaluation by a psychology colleague or a psychiatrist. Now, as I said, I worked largely in a public sector hospital, and I developed a program where we used to have group sessions with our transplant patients and bring them together so that we hear from them. And I thought our job was just sit there and hear from them, and after a while leave them to talk with each other so that they could perhaps just support and learn from each other's experience. And this would be a mix of patients. Some patients would be with well-functioning grafts, others with not so well-functioning grafts. So what have they learned from their life lessons, and what can they share with each other was one way. I thought we found that it made communication easier. And if after that, if patients had some questions, they could come to some of us in a group and we could discuss those issues with them. Some of those included psychological issues, other included medical issues which had psychological significance. And so I thought some of those interventions, which are relatively low cost interventions, but do require us to devote some time because we need to make time for that. But we thought they were worth doing. Again, as I said, resources are an important issue in our practice. And so just to justify investment of resources for a few tests is something that that requires time because the patients might want to know, why are we asking for such a test, And so if we get that done within a group of patients so that one patient can hear some reinforcement from a peer rather than just from the doctor, that helps. And that helps take away some of the psychological pressure also that the patient might feel. So those are a few things. I think once the graft starts failing and the patient is ready to go on a transplant, then that raises a whole different set of issues. And for that, we need to have better preparation. And I go back to the point of learning from the oncologists. And we have, as a community, at least in many parts of the world, not been so good in having a clear discussion around supportive care, shared decision making on the issues of failing a transplant as to what are the possible options available to them within the given situation. So it's possible clearly that some of them may not have the option of going on a second transplant. So providing them with supportive care options and thereby reducing the psychological impact that they are facing and the burden they and their family is facing, helping them with grief counseling and so on is also an important aspect that we don't often think about.